to Keeping You in the Family with Dr. Margaret Aranda on the CAW360 Network. Good evening, Call Nation. Here she is, Dr. Margaret Aranda.
Hi, thank you so much, Brian and Jonelle. I really enjoy my time here with everybody, and thank you so much for all your work and all your help. This is Dr. Margaret Aranda. Welcome to Keeping You in the Family. I'm your host today, July 24th, 2019. There are two ways to listen into tonight's program. The first is to go to the website at www.cawnation.com and click Listen and Play, or you can go ahead and go to YouTube, and in the search bar you can type in Keeping You in the Family. And please make sure to subscribe to our channel and to all of CAW360 Network. Questions for you also. You could call the studio line at area code 415-403-2715. And if you have any future mailbag questions for me, any questions about any of the shows, please go ahead and email them to Jonelle, JONELLE .Elgaway, ELGAWAY at CAW360.com. And just a reminder also that all of the CAW360 shows will be taking a summer break for the next few weeks after tonight's show. So before we get into tonight's topic of pain medication, we did have a couple of mailbag questions. Somebody asked about taking vitamins B12, B6, vitamin C, and D, and magnesium, and wondered whether taking 2 to 3 times a week of these is fine if she can't remember to take it every day. And the answer to that question was yes. Of course, it's just like it's better to get up off the sofa and stand up for five minutes. It's better to take some vitamins rather than none. And every single thing that you do to help your health is something definitely that is worthwhile and worth doing. So definitely keep up with all of that. And we're going to go ahead and review some of the things that we've already spoken about just briefly, but I encourage you, if you haven't already done so, to start from our very first show on diet, especially if you are a pain patient, and see if you could glean some information from there that you could ask your doctor about. Particularly. Otherwise, there's nothing on this show that's meant to give specific medical advice to any particular individual. You need to be seen and examined and have your past medical history and your surgical history, your medications, all of those things for good medical advice. So nothing's really advice for any one particular person. Tonight's show is called Trust Me Enough, Combined Therapy for Spinal Cord Injury and Central Pain. And we came up with that title. Melinda, actually, our office manager, helped me come up with that because over the course of about a year, we find that the patients that trust me from the beginning and take pretty wholeheartedly many or most or all of the things that I ask them to do very, very seriously and start doing them right away will get better faster and have better outcomes. And we've noticed that over time. So we started telling people to just trust me. I mean, a lot of people don't like to trust doctors. So we try to get past that one point and go on to the next level. And on the next slide, you can see that I chose a really positive figure here for today's talk. You're leaving pain. Enjoy the journey. So a lot of patients in my mind, as I used to be, felt like I was at the bottom of a well and I was in pain and I was suffering. There was no light, there was no warmth, there was no love, and I felt very lonely and by myself. And one of the biggest things that we do in our clinic is try to take that PTSD away from you, that post-traumatic stress syndrome, and get you out of who you are when you come to us and get you back to who you used to be, the person that you liked. Because a lot of pain patients tell us, and I remember it myself, I didn't even like who I was as a person. I was hard to live with myself. I could talk about nothing but my pain. And you can't be that way if you're going to be in a family, because you have to take care of others around you just like they need to take care of you. So a part of this is a mindset. Our series on the next slide, you can see, is keeping you in the family. The very first talk we did was on diet. Then we went over sleep, sex, and sex hormones. We talked about a lot of bone and joint and nerve stability, as well as anti-inflammatories. We devoted a lot of time to topical and regional anesthesia with an emphasis on epidural steroid injections. We gave a big talk on microglial cell inhibitors, which are pain medications that you should look for in your treatment plan to help your pain, especially if you have anything going on with your spinal cord or your nerve roots or herniated discs, anything that can press on a nerve. Today, we're going to talk about pain medication and end our series here. When we come back, we'll talk about PRP or platelet-rich plasma, as well as stem cells. And I found a really great quote on the next slide by Frank Crane. Trust me enough. You may be deceived if you trust too much, but you will live in torment if you don't trust enough. And that's my message to my patients, because I know they're used to not trusting doctors. And I know I ask a big thing to ask them to trust me. And I appreciate everybody who puts their trust in me and for allowing me to participate in their health care, because I take it very seriously. I don't want you to live in torment. I realize that you have been, and I'm here to get you out of it, because I got myself out of it, and God helped me. So I make no bones about it. I don't know everything, but what I do know helped me, and it's helped a lot of patients in our clinic who were suffering for decades. So I have every confidence that this kind of a recipe can help you too if you suffer from something similar. In the next slide, we're going to go over this combined therapy protocol that I'm announcing pretty much today. Nobody really knows everything that I've been doing, and this is the first time that we're announcing it to you. We're bringing it to the patients first so that you can multiply and go ahead and take our recipes and try to get your doctor to give you some of these things. So for diet, we want you to go on the anti-inflammatory Whole30. Try the antihistamine diet after that to make sure you don't need to be on an antihistamine diet, and then stick with the low glycemic diet to avoid diabetes and chronic metabolic syndrome and all the other things that are going to make you old and gray and more disabled as you age. We need you to sleep every night. We like magnesium plus melatonin. Green tea is awesome and amazing. It crosses the blood-brain barrier. Stay away from the internet and blue light in your eyes from the television set. Wear glasses, special glasses, if you need to get rid of that light, because it stimulates your brain. Epsom salts are magnesium. If you take a bath in bathtub water, you ground yourself to Mother Earth again. And if we need to prescribe something for sleep, I do not use benzodiazepines. I find that Ambien and Sonata, Zolpidem, Zalplon, those work very effectively for most patients. If you've had chronic pain, chances are your pituitary gland may not be talking to your thyroid gland or your adrenal glands or your sex hormones. So we need to take care of all of that. And I must thank Dr. Forrest Tennant for his emphasis and his help with me on this one, as well as Synergenics, who've trained me in age management to understand the endocrine system well enough to help people get their replacement therapy and add another layer of life-changing medication in this category. It includes over-the-counter pregnenolone and DHEA, which is dihydroepiandrosterone. It's a precursor, a pre-molecule to the testosterones and everything else. Estradiol, progesterone, testosterone. Some men in particular need estrogen blockers, and we check labs, especially the prostate gland, every 3 to 4 months in men. We check in women too, but obviously we don't need to check their prostate gland because they don't have one. On bone, joint, and nerve stability, we talked about the importance of all of that. We use some supplements, chondroitin, glucosamine, B12 injections, medroxyprogesterone is a great one for joints. Vitamins D3 and K2 are added together in a formulation that increases the absorption of each one of those. And your bone health is super important, especially if you're on steroids, especially if you started at a young age. Anti-inflammatories, steroids, and regenerative medicine are a huge component for pain management. We use injectable ketorolac, some methylprednisolone tablets, and more of the high-tech solutions include PRP and stem cells. Topical and regional anesthesia, we talked about compounded creams, getting them into your system, into deep tissues by using an infrared light wand. And also we gave you the science behind epidural steroid injections, as well as what the FDA has to say about it. So you need to watch that one to really understand what we're talking about there. But yes, they are not FDA approved. Microglial cell inhibitors is probably one of the most important talks I gave in this series. We explained what microglial cells are. We use the worst case scenario of pain in chronic regional pain syndrome, as well as we talked about supplements and prescriptions along those lines. And thank you very much for staying with us this far. We're talking about adjuvant therapy as above. All of those get incorporated into every patient's plan. And combined therapy in this talk includes 3 specific medications: clonidine, tizanidine, and ketamine. And last but not least, we talk about opioids. So you cannot talk about pain management without talking about the difference between ascending and descending pain. And this all starts around the spinal cord, which is surrounded by the vertebrae, which protects it. The spinal cord obviously runs up and down. You can see that little butterfly inside of it has to do with the different nerves that are connecting in there. And the nerve roots are exiting from the left and the right, and each one of those nerve roots has half of it that goes into the spine and the other half goes out of the spine. And we have a question from Lovett, and I'm so happy to see you here again, Lovett. Thank you for joining us. Is it advisable to buy DHEA and take it, or is it a specific drug you would need testing for, and would it help overall? Yes, it would help overall. Many people take DHEA as a supplement over and above everything else. Some people don't, quote unquote, believe in it, but there are a lot of papers that show that it can have some benefit. If you go back to the talk that I did on sex hormones, I explained to you the whole cascade and how DHEA and pregnenolone are the 2 that start the whole cascade of sex hormones, and actually the corticosteroids also. So yes, it's important. And yes, if you're taking any of these supplements together with or without replacement sex hormones, you should have your blood tested before you start anything, and then to see what the levels are and to see what you need replacement with. And then every 3 or 4 months thereafter, it should be checked again, everything all over again, to make sure that everything is staying in balance. So on the next slide, you see the whole spinal cord, the bones there, the vertebrae, going from the head down to the tail. It gets a little bit complicated. If you take a cross section of that spine, that's in the bottom left pink circle, we see the gray matter and white matter are in the spinal cord itself. You see the blue spinal nerves coming off of each side from left and right, and see how each one splits in 2 at the end like a split end. That's because Your legs are sending afferents up to your spine. So the first order afferents are from your skin or from your muscles or your organs, your bladder, goes up to the spinal cord. When they get to the spinal cord, they meet another second neuron. That second nerve fiber goes from the spinal cord, and some of them stay in the spinal cord. They're interneurons. They go a little bit up and down, or they stay at the same level, but they don't go to the brain. The third order neurons go from the interneurons to the interneurons, and the fourth orders go up to the brain. When you kick something, your one wing of that blue split end nerve root has to send motor impulses out to move your muscles. So the efferents are going out, and they go from the brain or the spinal cord to your skin or your muscles and your organs. So it gets a little bit complicated, but if you understand this, you'll understand part of why some of the medications work as well. And you see on the next slide, another way of saying that, we're splitting this up from the brain to the midbrain to the medulla, which is below that, down to the spinal cord. So you can tell that it gets complicated. At each level going up, there's something else going on. There's more processing. So the ascending fibers are going from the bottom, from the skin and the muscles and the organs, in black on the bottom left. And they're ascending up the spinal cord through the medulla, the midbrain, all the way up to the cerebral cortex, the insula, the amygdala. And then for the muscle to kick out, or for you to move your hand away from a burning stove, the descending fibers come from your brain through the hypothalamus to the nucleus cuneiformis, the periaqueductal gray, the dorsolateral pontine tegmentum, the interneurons, the rostral ventromedial medulla, and then down. So they've identified some very specific things that can really help. Amanda is asking, is CRPS, that would be ascending pain because it goes nerves to brain, not brain to nerves, right? Yes and no. So definitely your brain is interpreting the pain. Those are the ascending fibers. But when you're feeling that your leg is turning red, when it's swelling and getting edema and fluid buildup in there and swelling, those are efferents. That has to do with nerves that are going back down to that area. So certainly the pain fibers are starting from the skin or the muscle or the nerve areas and going up to the spinal cord. So in order for you to feel pain, it starts down at the leg, say, and goes up the spinal cord to the brain, gets interpreted there. And we're going to talk about the difference between acute and chronic pain also. And then once it gets interpreted, it sends a signal back down again so that you can move, because you're always moving when you're awake, for example. And also those fibers are connected to the autonomic nervous system as well, your blood vessels, your heart, your lungs. So fibers are going up and down the brain to those areas as well. On the next slide for pain pathways, I kind of split it up a little bit more because it gets more and more complicated, but this is a lot about what we know to particular areas. The ascending pain goes to a particular part of that butterfly inside the spinal cord. They are divided into sections called rexed laminae. They're numbered 1, 2, 3, 4, 5, 6, 7. And some particular ones connect to different areas, and they're very specific areas. The interneurons are the ones that carry opioid receptors and get activated. If they get too activated, it's what we call hyperpolarized. There's no relaxation of the firing. And what happens is that substance P can be released. And this is where different substances may block pain by inhibiting firing of those sections. When we talk about descending pain or suppressing spinal cord impulses, that starts from the upper brainstem through the periaqueductal gray matter, which releases enkephalins. Enkephalins are opioids that your brain makes itself. They're endogenous opioids. that your brain makes. The locus coeruleus is another area of the brain that releases an adrenergic hormones, and the raphe nucleus does 5-HT and serotonin. So that's why, some things like Prozac may cause some action in some of these different hormones that get secreted by the neurons. And then there's identified areas in the nucleus reticularis as well as the gigantocellularis. And all of these things going on in your peripheral nerve, the interneurons in the spinal cord, the ascending neurons going to the brain, the descending neurons going back down again to the interneurons, then the interneurons talking to each other, then the descending nerves going back out to your legs. Really, if your brain is receiving pain signals 24/7, most particularly, I think, when that pain has a burning component to it, like CRPS and arachnoiditis have, that 24/7 intractable pain that is unrelenting and burning, it wears you out. It changes your brain. So the feeling that you feel of being worn out and feeling like pain is your life is like when I was talking about pain in the Rebel Patient book that I wrote, I likened it to a redheaded stepchild that was in your face all the time. You're trying to be around other people. You're trying to do something else, but you always have this other thing in front of you screaming at you. It's really hard to ignore that. So our job as doctors is to tame that. It changes the personality. It distresses you. I know it diminishes your memory. It diminishes your muscle strength because those nerves and the body parts are not being used normally. It can definitely make you very anxious as well, and that's not a nice feeling. When you're anxious about your medical condition, that's one thing. When you're anxious about what the doctor's going to say or how you're going to be treated when you go in there, that's another thing. Another third layer is what the pharmacist is going to say and whether you're going to get the medications that your doctor prescribed for you. That's another layer. Paying for the medications, having insurance cover it, delays and refusals, and having to put in prior authorizations. There are a lot of loopholes that pain patients need to go to, and each step of the way can be extremely anxiety provoking and maddening and frustrating. So it is absolutely no surprise that this fosters depression. It fosters changes in personality, so you may not even like who you are. It definitely can take your hope away if you've been beaten down every single step of the way and nothing ever seems to go right, not just for a day, not just for a week, not just for a month. I'm talking about month after month after month, after year, after decade after decade. Some people have lived with excruciating pain that's never going to go away. It's our job as doctors to make their life tolerable. And that's a relationship that we have with them. When that hope is taken away and when there are barriers to that hope, and when somebody is beaten down and there is no one that can do anything to help them anymore, it is not surprising that a patient may feel that their only alternative is to commit suicide to be free of the pain. And Kimmy Miller and I, we started #SuicideDueToPain on Twitter several years ago, well before I got involved with our clinic. And it's a sad situation that such a hashtag even exists in America today. And it's there, and it's always been there. It's just that now it's getting worse. So my job to you today and my job in my clinic is to make sure that this doesn't happen to you. And all of us doctors in pain medicine, most of us have had somebody who's committed suicide. And most of the time, our patients really love us. They've never said anything bad to us. They never told us they were going to do this. It always surprises us. I've spoken to many doctors about this. You know, we're not here to judge anybody. And I think that it's reasonable to think that that's something that some people feel is their only option. And it's very sad when there are confounding variables like insurance companies who don't want to reimburse for pain medication, who don't want to reimburse for anything, who don't even think the patient has anything wrong with them whatsoever. They think they're pretending. It's really hard to have a lot of people judging you when you're in that kind of pain. And it's a life that none of us know what it's like. We can't really identify 100% with it unless you're afflicted with it. So the most important thing that I think is that we keep giving our patients hope. We give them as much as we can. There are limits to everything. There are agreements that we have. We have a pain agreement in our clinic, just like most other clinics do. And our patients sign them every month just to make sure that they're refreshed about it. So when acute pain becomes chronic pain, you can see on the next slide also, I actually wrote this article in 2017. There are 7 different items, and that's just a partial list about how your brain changes when you have chronic pain. Not only are different areas recruited in number 1 here to process the pain, but in number 2, you can see that the touch pain, ouch, it hurts when I touch it, changes, it shape shifts to emotional pain. It goes to emotional centers, the amygdala in the brain, that makes us think about the pain and associate the pain not just with pure pain, but with different things, anxiety, depression, just sharpness, dullness, achiness, whatever descriptions you have for that pain, it takes a life of its own. And not only that, but in number 3, there are some patients who are hardwired as to who will develop that chronic pain after a year. So if you happen to live in a body that was hardwired for acute pain to lead to subsequent chronic pain, to subsequently change your brain and hardwire things different way, that's what the body is that you were given, and you can't change that. For patients who have chronic pelvic pain, patients who have unrelenting 24/7 pain inside the rectum, over the groin area, the penis, the clitoris, the testicles, 24/7, they change how pain is processed as well. And with patients who have the complex regional pain syndrome in number 5, we see that they actually get a distorted body perception. And one of the physical therapy maneuvers that can be used in the first 3 months of a diagnosis, or with even just an extremity that has pinkness and swelling, you can put a mirror, say, next to your ankle, look at the mirror image of the ankle as well as directly on the ankle, and somehow imprinting that mirror image in your brain shows you a different way of looking at your foot, except straight down on it. And somehow that distracts the brain enough to make it get better. So that's definitely a good use of the information that we have and the technology that we have to implement some parameters that can help us get out of the pain. And some people are very vulnerable. Some people have very huge reward centers, very big motivation centers. Some patients have differences in their descending pain and the way that it's modulated. Some patients are more prone to develop depression. And it's not your fault if that's the way it is. That's just the way your body was made. So let's just take a moment here and step back. That's the science. That's what we have. And our goal in the next slide is to use combination therapy to make you better. So the number 1 premise in our clinic is No longer can we think that one medication or one class of drugs is the end-all answer to your pain. Your life may be very much helped by opioids, for example. Your lack of opioids may make you think a lot about that. But that doesn't mean that that's the only drug in the entire world that's going to make you get better. And if you think that that's the only thing that's ever going to help you, that's probably not the best way for you to think. We have a microwave society. There's no reason to think that the damage to your body can be similarly placed in a microwave oven and heated up in 20 seconds or whatever fantastic fast time there is, and miraculously you're better. It's just not going to happen. We have to hit your pain a lot of different ways. We have to wrap our arms around it. It's big. It's complex. And so if I can just get you out of thinking that your end all is one particular drug, you'll step out of that bottom of the well. I got to get you out of there. And this is your first step. Combined therapy. Change your mind and change your thinking. It's not one drug that's going to make you better. It's a lot of them. So the next slide will show us that multiple medications that have multiple mechanisms of action can attack your pain. Not only are they needed to help you get better, but they're necessary because you're probably lacking in several things that you need back before we can make you whole. And I hope that makes sense to most of you. I think it does. It's hard to practice it though. So number 3, I'll say it more specifically in this line here, and you may not like me for this, okay, but I'm going to say it. This includes opioid end-all brainwashing and the marketing that companies have brainwashed us with. I want you to know that opioids are not the final ultimate answer to solve central or chronic pain. They're not enough. If anything, opioids cover the pain. Does that make sense? It can take the pain away for a moment, for an hour, for 4 hours. But as soon as that opioid wears off, what's going to happen to your pain? Did it heal your pain? No, it covered it up. So there's a difference between healing the underlying problem and covering the pain. In the next section, these are the 3 drugs that I have found most helpful in our clinic. And Dr. Tennant agrees. I had a hiatus away from him, some time away from him to analyze the whole clinic, all the drugs everybody was on, and see what I thought was going to work when I changed it up. I wanted to switch it out and I wanted to make it mine. The first drug that I put everybody on, that I tried to put everybody on, was clonidine. Clonidine is an imidazole. That's the chemical group that it is. It's a centrally acting alpha agonist. So it works inside the brain and spinal cord. It basically stops the spinal cord from talking to your brain. Tizanidine is structurally similar. It works on ascending pain as well. It's a central alpha agonist as well. And Xanaflex is a trade name. Catapres is a trade name for clonidine. Those two are relatively similar. They have different profiles though. And if you can take both of them, I can guarantee you that your pain will get better. Neither of those is a scheduled drug. Neither is an opioid. Neither is a benzo. It's any doctor can write for it. There's nothing magic about it. However, I don't give tizanidine unless I find that you need it on physical exam. The third drug that I like to use is ketamine. It's a scheduled drug. It's a Schedule 4. I can write refills on it. So that's easier for me. It puts people in a good mood. It's a cyclohexanone derivative. It works in the spine. It's an NMDA antagonist is the class that it is. And it's generic. And it comes in a bottle and it's cheap. And you can also compound it and change it up, add other things to it. and we find that it inhibits central sensitization. So the combination of these 3 drugs, if I put a brand new patient on all 3 of these, say within the first 2 or 3 months, and they can go on a dose of these that's pretty decent dose, boom, I can 90% guarantee them you will be significantly better. And I think that's amazing. On the next slide, we'll talk about doses and more particulars about each one. Clonidine or cataprest starts at a dose of 0.1 milligram. It can go up to 0.6, and that's every 8 hours, and there is a patch. So you want this drug to be like a continuous infusion. You want it to be in your body and stay in your body. If you take it away after you've been on it for a while, your heart rate might go up too fast. You may have a whole lot of pain because your body wants it and needs it. There's a slight withdrawal syndrome from it, but that's just based on your heart rate and blood pressure. It's not because there's anything in your brain that tells you you need it. It's not addictive in that kind of a way. Most people get a little dizzy on it. They could have trouble standing up. It can make your heart rate go down. That's one of the benefits of it. A lot of people get a dry mouth from it, but we can also calm that down in different ways. The benefit is it stops the ascending pain fibers from reaching the brain, and in that method, I think it helps reverse central 24/7 pain, so it relieves your brain from constantly being bombarded. It decreases pain. It potentiates opioids. Many people can get more sleepy on it because it makes the opioids stronger. It can treat withdrawal. I tell people in my clinic, I never want you to be without it. Put some in your car, take some to work, because if there's an earthquake out here or anything happens and you cannot get your opioids, this will help you get out of it. You should never be without it. It will decrease the sweating, the abdominal pain, the high blood pressure, the fast heart rate, a withdrawal, and decrease anxiety. And by that same method, it could also lower your blood pressure. We have a caller from area code 530. Hi, welcome to the show.
Hi there, Dr. Aranda. It's
Hi.
Julia Gillespie here. Hi there. I had a question about what would be a difference between, say, using LSD versus ketamine, since correct me if I'm mistaken, that they're both dissociative anesthetics class, yes?
Well, okay, so let's talk about LSD separately. LSD, I could never prescribe that, of course. It's a Schedule 1, so it's illegal. Most people can't get it. So I've never used it. I've never used it on anyone, and I don't know exactly how it works on a patient because I've never seen anybody on it. So I don't have any personal experience in that way. But you're right. The thing about ketamine in particular is it does have something called dissociative anesthesia associated with it. And we're going to get to that. I have that in two slides from now. I'll explain that one a little bit more particularly. But there's no comparison between LSD and ketamine to a physician because one's legal and the other one's illegal. And so if you separate that out and just talk about the mechanisms of how they work, some people can have hallucinations on ketamine, but usually if that's a high dose. In our clinic, I start everybody on a low dose, and they're not supposed to be having a lot of negative side effects. They're just supposed to feel some effect with no side effects. So, and some people may be particularly predisposed to have hallucinations or have a negative effect with any drug for that matter, not just these. And if that's the case, we tell people to stop taking it. So there's a standing rule in our clinic. If you're put on a medication that's new to you and you have a side effect, you stop taking it. Depending on what the side effect is for you, if you fall and break your nose, you're never going to go back on that drug. If you get lightheaded when you stand up, you can stop taking it for a couple of days and try taking a quarter of the dose or an eighth of the dose on Monday, Wednesday, Fridays, and then slowly increase that over time. And I'll tell you, especially with clonidine, for example, that has a lot of side effects and not everybody can take it. However, if I put you on that drug and say, here's a drug for you, go ahead and take this for your pain, you'll talk to your pharmacist. They'll say, oh, I've never heard of that, because we had to explain to almost every single pharmacy that clonidine was for pain because nobody knew, not even the pharmacists knew it. However, for a whole entire clinic, for those people, except for somebody who fell and broke their nose, most people who had negative side effects from clonidine in particular, once I did an 8-page write-up to explain these 3 medications and how they work and why they're so important, almost everybody who had a negative side effect to clonidine wanted to go back and take it again and try to make their body take it more slowly and try not to, just basically try to take it as much as they could. And many people were able to go on it, albeit at low doses, or maybe just at night to sleep with for 8 hours, but gets them sleeping and it calms their spinal cord. And then the other one, just the last comment I'll make about LSD there, lysergic acid diethylamide. It's definitely, its main function is to change mood, and it's a very, very potent hallucinogenic. So okay. I otherwise don't know how to answer the question. So I hope that helps.
You absolutely did, and I have a whole page of notes, and I appreciate your help so much, and I'm going to keep listening to the show. So thanks so much, Dr. Aranda.
Perfect. Thank you, too. I really appreciate the call. Thank you so much. And then I think somebody else also had a question asking about how SSRIs work. SSRI stands for selective serotonin reuptake inhibitor. Has to do with serotonin. So if a nerve, the end of a nerve allows serotonin to come out of it, what those do is they stop that serotonin from getting uptaken into the next nerve so that its concentration accumulates. So it increases serotonin between the nerves, and that's very helpful for the brain, and that's why that's used as an antidepressant. They're relatively safe, and typically they'll cause fewer side effects than other antidepressants, and that's been a good thing for many people to have. The main cause of action is because serotonin is a neurotransmitter that carries signals between the brain cells, and the serotonin selective uptake inhibitors, they only affect serotonin, not the other neurotransmitters in the brain. So that's why those have been so helpful. And thank you so very much, Julie. Caller, we have another caller from area code 216. Hi.
Hi. This is Luca.
Hi, Luca. Do you have a question for us tonight?
Yes, I do. First of all, I was attacked back in 2013. I had to have 2 bones removed from my neck, and I had the vocal cord nerve severed.
Okay.
I have a lot of pain that goes down both arms and my upper back. I can't sit up most days.
Okay.
But I was one of the ones that after laying in bed for 5 months and dying, I went out to the streets. I got a heroin charge. What if I came in to a doctor like this and told her what went on? I'm not a drug addict. Would they treat me? A lot of people want to know. So I thought I'd brave it and ask.
Sure. No, thank you. No, you have really a legitimate injury. Obviously, I could tell just by the way you're talking, your vocal cords have been affected. I don't know which bones they took out, but any bone they could take out in the neck has to be in the vertebrae, and that has to have affected your spinal cord and the nerves. I'm not surprised you would have both of your arms with pain, if not muscle atrophy and a lot of other symptoms as well. If you were in a situation where you were unable to obtain pain relief from a local physician and you had nothing else to do but go on a street drug, I totally understand that. I think most doctors are kind of used to seeing that these days. It's not surprising to any of us. To be seen in my clinic with that kind of a history, we'd have to be just pretty much upfront with me. And then obviously I'd have to work with you so that we would find something that you could live with, so that you wouldn't have to go to the streets. So you never know what you're getting. There's a lot of stuff laced with a lot of badness, and that's a big risk, of course. So that concerns me for you and for anybody else.
Pain meds. I was on opiates, and I was on Xanax at the time. Then my doctor cut me off in 2016.
Gotcha. I think this is a common scenario. I definitely think this is a common scenario, and it's one that's potentially we're going to see more and more of this as time goes on. And no, I would not, as a physician, deny treatment. I would not reject you from my clinic because you used street drugs because there was nothing else in your neighborhood to go toward and you didn't want to kill yourself. I mean, you can't be damned if you do and damned if you don't. You have to do whatever you need to do to survive, right? So
currently I use kratom. That's also in a threat now to be taken away.
Right, and I'm very familiar with the kratom use. I'm going to go ahead and go on with the slides, but I'm going to go ahead and address your situation too. So, yes, if that's your history and that's what you come with me on and that's what you've had to go through to get to where you are right now and stay alive, that's just the way it is. I'm not going to judge you for that. But in our clinic, you will sign a pain agreement that you're not going to do more of that. And I'm going to do my best to try to give you normal, healthy drugs that are safer and pure, and we know what's in them so that you're not exposing yourself to a lot of risk. And if you need to, come off of something, I recommend going to a private ketamine infusion center or getting a detox center, paying cash for that. You can detox off of a lot of things and sort of reset your body that way. And I'm going to go ahead and continue going on for the benefit of getting through the slides. But you can ask any doctor to prescribe clonidine for you. And on the next slide, you can ask any doctor to prescribe tizanidine for you, especially if you have a nerve injury and you have myoclonus or jerking. If you're jerking the bed at night, waking up, your spouse is complaining about it. Tizanidine is similar to clonidine. It stops ascending pain fibers from reaching the brain. It helps, and it's FDA approved for spinal cord injury as well as multiple sclerosis and muscle spasticity. So the lowest dose is a 2 milligram tablet, but you could start with a quarter or a half of a tablet and slowly go on it if you need to. The maximum dose is 6 milligrams. That changes from tablet to a capsule in the 6 milligram form. Some patients I have are on 7 milligrams 4 times a day, but it's only FDA approved 3 times a day. That one, similarly to clonidine, can cause dry mouth, fatigue, and dizziness. But the beauty with these medications, clonidine and tizanidine, is that they're healing your spinal cord. They're healing your nerve roots. They're stopping overactivity. They're calming your brain, and they can do it while you sleep. The next medication is ketamine. I spoke about ketamine infusions. We've sent several patients. I have sent several patients for ketamine infusions. Each one has had a positive outcome, especially if you're requiring higher and higher doses of opioids and your physician is uncomfortable prescribing high doses or does not want to go higher. That's his or her choice, and you have nothing to say about it. It's also your quandary because that's your body, and your body's asking for more. Well, it won't ask for more after you get through with a ketamine infusion if it's possible for you to do that. So go ahead. It inhibits NMDA receptors. It's anti-inflammatory. It enhances a descending inhibition, so it helps pain several different ways. Studies show also that it increases the brain density of nerve fibers. It not only makes nerve tracts thicker, but it increases the number of synapses or fingers projecting out of each nerve, so they're talking to each other a lot more. There's no maximum goal for this drug, for the dose. In fact, I don't want people to be on real high doses of this either, because you'll get into more side effects. Clonidine, max 0.6 milligrams 3 times a day. Tizanidine max, 6 milligrams 3 times a day. Ketamine, I don't like to give any more than about 12.5 or 20 milligrams several times a day. A lot of people can get an upset stomach, dissociation, but honestly, for most people, if you as a pain patient have had nothing but pain for decades, and I tell you that I could put you on something that will take your pain away and it'll throw it out in the brain, in the world somewhere, and take it out of your brain, and you'll forget you even have pain. You'll have to look up at the wall, looking and trying to remember where your pain is because you'll forget you even have it. That's the dissociation part of ketamine for a pain patient. It makes you separate from your pain. And most people will give anything and get a great benefit of even half an hour being without their pain. It's a very strong analgesic. We use it to change burn dressing changes in patients in the intensive care unit. It's great for CRPS, or complex regional pain syndrome. It is great for burning pain. It takes burning pain away. And to me, that's some of the worst kind of pain that we see in a pain clinic. You have to watch the liver and the urinary bladder. You might pee blood. If that's the case, you have to stop taking it. And you have to watch for psychotropic effects. And you can calm those down with oxytocin or benzodiazepines if you have to. A lot of the ketamine infusion clinics will give you benzos together. We have a caller online from area code 734. Hi, you're on the air.
Hello?
Hi, you're on the air.
Hi, thanks for taking my call.
Sure.
I just tuned in, and it was good timing. The doctor spoke about ketamine, and I'm scheduled for a ketamine infusion, and if it's successful, they'll switch me to an oral drug. But I remember the oral drug being called something different than ketamine. Are you familiar with that, doctor?
I don't know what they were thinking. It's possible to compound ketamine into capsules.
Sorry. They said it's a drug used in Alzheimer's patients. And
I don't know what they're thinking. I honestly can't answer that question. There's so many drugs out there. I'm not sure what they're referring to. If ketamine works, then to me, you should just continue getting ketamine. You give it as an outpatient as well after an infusion. So I'll go ahead. You actually are segueing into my next slide on combined therapy, and I'm giving you the recipe here. So go ahead and go back to the slides, okay? Thank you so much for your call. So the next slide has the combined therapy recipe that we use. In white is the clonidine, in orange is the tizanidine, and black is the ketamine. So there are the doses, the frequencies. That's pretty much what we're doing. And we do continue with ketamine on an outpatient basis. It comes in a concentrated vial, 50 milligrams per ml. Some patients can inject it subcutaneously as if it's insulin, and find a lot of pain relief, especially from the burning pain. And the other way is you can compound it. I can ask a pharmacist to make a recipe for me by hand. That's compounding. They can make it into a wax square that goes up in the upper cheek pocket, or they can pour it into a capsule from the powder and make a capsule any strength that I want them to make. There's really no limit. But again, ketamine by itself for some people is not a good drug. As an anesthesiologist, we're used to polypharmacy and mixing different things. Dr. Tennant showed me how to use oxytocin. It's a hormone that women normally secrete during childbirth and breastfeeding. Puts you in a good mood, makes you want to be around other people, stabilizes. It's used for depression a lot these days. It's not unusual. And I'm very grateful for what Dr. Tennant has taught me. So it also increases saliva. So it treats the dry mouth that clonidine and tizanidine can give you. And you can, as a troche, wax square, you can put it in your upper cheek pocket outside of your teeth. And then when it melts sort of and gives you that extra saliva, you hold it under your tongue and recycle it as a sublingual formulation that gets absorbed from the veins that are underneath your tongue. So you can get a lot of bang for your buck. The next slide is the mechanisms of action of how these three drugs work. Clonidine stops the pain from talking to your brain. Tizanidine does the same thing, and it stops the nerve roots from sending spasms out to your muscles. So almost nobody in my clinic is on Valium or benzodiazepines for muscle spasm, because why should I do that? when I can calm the nerve root down and heal you from the spasm in the first place. I'd rather go to the origin of the problem and not have the side effect of the spasm. So we're healing the spasm by treating it at its root cause. Tizanidine, in my opinion, is a very underappreciated drug that should be used a lot more often, and I think that we'll see that happening. So ketamine takes your brain and puts it somewhere, it takes your pain out of your brain and puts it out there somewhere else in the world so you can forget about it for a while. So it reverses central pain. And I think now we're going to finally start talking about opioids, but you can see what a small part opioids have in our clinic. There are tons of opioids. They're all listed on the left for you as generic names. On the right side are the trade names, and you can look at that at your leisure. The next slide, those are the 4 that I use the most. I don't like mixing with acetaminophen, with Tylenol. I don't want to damage your liver or your kidneys or give you a GI bleed, an ulcer, so I stay away from the ibuprofens too, although I do use the injectable ketorolac. So if you get to use a lot of opioid, I'll finally probably convert you to a fentanyl patch. Otherwise, if you come to me and you need a lot and you need it, but because your body is used to seeing a lot, I'll take you straight to injectable hydromorphone, because basically it'll stop you from crying for opioids. We'll just give it to you. What are you going to do when I give you an opioid and your pain is gone? What are you going to do next? What are you going to do with your life? What are you going to talk about when you have nothing left to talk about because your pain is gone, because you get what you want? You need to think about that. The country needs to think about that, because a lot of people are duped into thinking that their lives are revolving around this, and it doesn't have to. So oxycodone I like a lot, and in the next slide you can see that those are the side effects. They're pretty standard, and we just work around them in the doses. The next slide, you see the adjuvant therapy, the microglial cell inhibitors, the sex hormone replacement, the combined therapy we talked about. Those are the diagnoses we see a lot of: CRPS and spinal cord injury. And thank you so much, Jonelle. She says I can keep going as long as I need. I really appreciate that. Because listen, we've spent how many sessions, an hour each, on all of these subjects. This fills the entire slide. And where do you see an opioid on this slide? Nowhere. I'm telling you, opioids are a very small part of your pain. Okay, because you've got a lot of microglial cells. You've got a ton more microglial cells than you do neurons. And opioids only act on opioid receptors. And there's only a certain number of those in a certain number of places, and there's nowhere near as many of those as there are microglial cells. So I want to emphasize there are a lot of drugs that you can take, a lot of supplements, a lot of things you can do to calm your pain. And most of them are not opioids. And most pain that we see in our country comes from low back pain, neck pain. Some people have surgeries or amputations, but a lot of people have a herniated disc or traumatic brain injury, fibromyalgia, adhesive retinitis, and chronic regional pain syndrome. So yeah, we're talking about a lot of diseases. If I, in my clinic, can help a huge diagnosis like adhesive arachnoiditis with all of these medications and resorting to opioids, 1 or 2 or 3 or 4 different kinds that I use in the entire clinic, why can't this work for your pain? So I think you should be hopeful and very positive about moving forward, asking your physician if you could have a Medrol dose pack. Can you prescribe some metformin for me? I'd like to try pentoxifylline. Can I try some clonidine or some tizanidine, please? Can you prescribe me a microglial cell inhibitor? They'll stop and say, what's that? Maybe they don't know. And maybe they need to know. And it's not their fault. I don't know everything. You've heard me say I don't know. I say I don't know a lot. So that's my adjuvants. And then here's my combined therapy for spinal cord injury on the next slide. 4 opioids. So Amanda's asking, what dosage do you use for patients getting ketamine infusions? Ketamine infusions are very specific for each patient. Some centers can give as much as 400 milligrams on one dose over 4 hours, but it depends if you're getting the infusion for mood or for pain. Ketamine infusions, that's a whole other, I could talk an hour on that one. But there's a long history of ketamine infusions being very successful, and ketamine as an outpatient being very successful for mood, depression, anxiety, panic attacks, even bipolar disease, and major depression that's been resistant to something like electroconvulsive therapy, shock therapy to the brain. Ketamine infusions have been extremely successful in pain management. They've been popping up all over the place. So we can do ketamine infusions. We have to monitor a lot of different things and temper the ketamine. It's usually not given by itself. Usually a lot of centers have you pay extra for Zofran or for a benzo together with it, just so you don't hallucinate. Some people throw up from it, so we have to be prepared for that as well. For pain, for mood, you can go for an infusion for a day or two, for an hour. For pain, however, depending on how long you've had pain and what kind of medication regimen you're already on, a ketamine infusion may go for 4 hours, 4 to 5 days in a row. And those can cost anywhere from $1,200 to $3,000 each day, depending on who you go to and how many other patients they're watching and how much attention they give you. But everybody that I've sent for a ketamine infusion has done extremely well. So you have to have a little bit of money. Insurance won't cover that quite yet. But one would think that insurance companies should start looking at that because it's a cheap drug. It's used in veterinary medicine. It's a standard solution. It's pharmacologically manufactured. There's no shortage of it. So, and it's cheap. And you don't have respiratory depression associated with it at the doses that we're using. It actually keeps you breathing. So there's a lot of good things about it that we don't have to worry about compared to opioids. It will not lower your blood pressure. If anything, it will elevate it. The other caveat that I'll mention here, since we have a little bit of time, is S-ketamine. Ketamine is normally metabolized to S-ketamine. It's like a left-handed versus a right-handed molecule, structurally similar, almost exactly the same. But the FDA recently approved S-ketamine nasal spray. It's FDA approved for the treatment of medication-resistant depression. So it needs to be prescribed by a psychiatrist that you're seeing, preferably an MD, who's already tried you on 2 other antidepressants that have failed, such as something like amitriptyline or Prozac, and you have to be on a 3rd. It's not meant to be taken by itself. And then you come in to a center, somebody like me, I qualified as a center. We have to test for it and meet certain criteria, and they have to approve us. You have to go into the center to receive your nasal spray in the center, physician assisted. Then you have to stay monitored there for 2 hours to look for high blood pressure and high heart rate and vomiting and side effects that we can treat. And then you go home. In the first month, you'll come in twice a week, and then that tapers down to once a week. And individually, depending on your body and its metabolism, and how you respond to it, you'll either continue it, you'll succeed, or you'll fail. If you succeed, 1 nasal spray in the office may last you a week, or 2 weeks, or 3 weeks, or a month. It depends. But this is like really good news because ketamine can last a long time as a nasal spray, and it has such a positive long history of being safe, especially in the UK. It's been used for decades for this. And on the other hand, also, a lot of us feel that even though that's FDA approved, which is a big thing because it's the only antidepressant that's been FDA approved in the last 10 years, ketamine is still much cheaper. It's still pretty easy to give. It doesn't require you staying in the office for 2 hours if we're just going to give it to you as an outpatient. And so there are a lot cheaper ways of doing it than going the S-ketamine route. But I wanted you to know that that's available too. And then the very last slide here I have on combined therapy segued right into what you were asking about. Some patients may need a ketamine infusion every 3 to 6 months. It depends. If you're coming in to see me and you come in every month and you keep asking for more and more and more, I'm going to stop. And I'm going to write for you to go get a ketamine infusion. You don't have to get it with me. You can go somewhere else, go locally where you live if you need to. And most people that go end up getting one, and most people that end up getting one do extremely well. When you come back to me after your ketamine infusion in the following month, I can usually decrease your pain medications by a half or even more. You may be on a quarter of what you were on before the infusion. It's absolutely phenomenal. And I think that insurance should pay for it. Insurance should pick up this bill and they should mainstream it as something that's covered by insurance. It could be performed in a surgery center. It could be performed in a post-operative recovery and anesthesia recovery unit. It could make use of space that's otherwise not being used in a hospital. It could be because it's not expensive. It's really, really cheap. So I think that's underutilized, and I think it's a great mechanism to help a lot of patients with chronic pain. And I think that we will see more of that, and I think that we will see insurance covering more of it. And Christine is asking, could I ask for ketamine nasal? And I don't think it's very common, but certainly if your eyes start to turn yellow or your skin starts to turn yellow, that's your liver. And we check liver enzymes together with kidneys and other functions. And you see we're doing sex hormone replacement a lot. So we're checking all of that every 3 to 4 months. So if anybody's going to find it, we're going to find it first. And then Roder had asked, how does one reverse 50 years of nonstop pain, including nerve pain and pudendal neuralgia? Pudendal neuralgia can be grouped into chronic pain or chronic pelvic pain. For a man, that would be prostatitis. For a woman, that would be vulvodynia, where there's pain in or around the groin, the penis, the clitoris, the vagina, inside the rectum, to the right and to the left of the groin area, as well as the upper thigh. Some people also lose stool function and urine function. They dribble and they lose stool both. Is something that's not commonly talked about, but I want to actually do a show on that. How does one reverse that? Well, I would need to see you in person and examine you and get an idea of what your history is. That's a long history, but certainly you can go and try some things that you've never tried before. Look at the list of my slide here and try to make sure your hormones are replaced and you're getting B12 and you have metformin and pentoxifylline and you've tried some other things. I don't know if steroids work on you or not, for example. So it's trial and error. You may have to try twice as many medications as other people, especially given your long history. But I certainly think that ketamine could change your life. I think a ketamine infusion could change your life. So I would hold out hope for that as well. So Tammy is asking, is there an age when ketamine won't help someone? S-ketamine is not FDA approved for children or pediatrics. However, we use ketamine for burn dressing changes if a child has a lot of burns. It's used in pediatric anesthesia quite a bit. And as I mentioned, ketamine gets metabolized to S-ketamine. So one could say for S-ketamine, there is a young age group limit there because it hasn't been studied. And with adolescents, we have to be careful with any antidepressant that it won't increase the risk of suicide. But most people that have asked about S-ketamine nasal spray for depression in a teenager have already tried 8 or 9 different things and nothing's working and they're still cutting. So if your psychiatrist approves or writes a prescription for a consultation for S-ketamine and we meet the patient, I'm open to that. S-ketamine is so new that most doctors have never given a dose of it yet, even those of us that are centers. I have a lot of possibilities that we're working with, but no one has actually come in and received it yet. I have not given it to anyone yet. So all of us are a little bit in the dark with it, but many of us who have become centers did it because we know that the kinds of patients that would come to us for that have tried everything else and there is nothing else. And the caveat with that, as you can understand, is that you can't just walk into my clinic and say, hi, I want an S-ketamine nasal spray. No, your doctor has to refer you to us. So there's another doctor who's known you many years longer than we have and has recommended it. So we go on their recommendation. We trust that. So I'm going to go to the very last slide now. I want you to have somewhere in your brain a place that you think you can go to someday that allows you to leave talk to any pharmacist who fills for us, they're pretty impressed that as much as we know about medicine, endocrinology, anti-inflammatory, steroids, alternative medicine things, the chondroitin glucosamine, B12, all of these things. And they themselves have watched patients come into their pharmacies for decades, some of them, and they never got better. And they're seeing them now walking into their pharmacies looking a lot better. So I don't know. We have something. We have something that's working for some of the sickest patients in the country. About half of our clinic is from out of state. They can't find a doctor in their state to take care of them. They fly in suffering. They take a plane to a car, to a train, to a car, to an Uber to get to us. They suffer the whole way here. Then they suffer all the way back. And every 3 to 4 months, they suffer again to come all the way back. So we must have something that we're doing right. And I hope that you can take something out of what you've heard and carry that to your home doctor. Get them to listen to these videos if they need to. And we will be doing webinars for physicians so that we can teach them what we're doing. And each show in our series is a chapter in my next book that's going to be entitled Trust Me Enough. So I want to thank you for listening to us. I want to thank you for your calls and your questions. Drew asks, are university hospitals studying these things? I should think so. Many are, of course. Ketamine's an old drug. There's not a lot of money in studying ketamine quite so much anymore because it's already generic and nobody's remaking it, except for the S-ketamine that those people did for the nasal spray. But yeah, we need more studies. We need more patients enrolling in studies. It goes both ways. We need more funding from, people, paying patients, donate money to people to study things. Why should we get all our money from drug companies? Do you not think that affects the results of some things? I mean, drug companies shouldn't be running any of our lives anymore. We've, I think, as a nation, had enough of that. So I think people need to start willing some of their estate to doctors that they trust so that they can do some better work, buy some better equipment, make more people better. Because there's a big paucity, there's a big, huge gap of payment management in our country. It's not taught well in medical schools. Most medical students don't rotate through a clinic. I have some of the sickest patients in the country, and do you know how many medical students and residents and fellows and interns I have rotating through my clinic to see some really sick patients who cannot possibly be faking it? 0. So there's something wrong with our system. There's not a lot of people that are making patients better. And the doctors that are making patients better need resources too to make it better. There's a lot more that I want to do. There's a lot more that I could do. Plus, I want to replicate myself and start clinics that do what we do all over the country, and I'm happy to help do that. Because you shouldn't have to come across the country from Florida, New York, Staten Island, Anchorage, Hawaii, Chicago, Texas, Oregon, Washington, all over the state of California. Out of the country, they're coming to see us too. So yeah, we have something, and I'm glad you like us. I'm glad you like what you hear. I think you have a lot of hope. There's a lot of things you could do for your pain, and I'm very, very happy to have been a part of it, and I thank you for your time. Please, if you haven't already, go back to the beginning and start with the first video and watch this series. All the patients in my clinic are required to watch every single one of these talks. And most of the things that I'm taking from these talks, I've said to my patients over and over and over again. And be on the lookout for my next book, Trust Me Enough, Combination Therapy for Spinal Cord Injury and Central Pain. Because I think if I can get you to trust me a little bit, and we can get you a little bit better, I think you'll feel a lot better. because I know what it's like to have a knife sticking in you. And if we can pull that knife out just a little bit, I know you'll be able to walk. And I want you to walk. I love it when our patients come into our clinic. And for many of them, I only get to see them for a little bit of time. And I heard a quote on Criminal Minds that I'm going to probably flub up, but it goes something like this. I really hate saying goodbye to you, so that I actually really love it when I get to watch you walk away. And the reason why that quote means so much to me is because we're avoiding wheelchairs. We're getting rid of canes and walkers, and our patients walk. And that's what I want for you. So just bear with us while we take a little bit of a summer break and prepare some higher quality things for you and some surprises and some goodness. And re-listen to some of our shows on CAW360 Network. We have a lot of different things we're doing for you. Stay tuned with us. Thank you to Jonelle Elgaway and Brian Grimes for all your help. And I just thank God for the opportunity to be here talking to you. And want you to know how much we care about you, and we don't want you giving up. We want you to know and to understand pain and all the different things that are available to help you. Try them, ask for them, you do what you can, because I think that if any of these medications or any of these supplements can help you a little bit, remember, each one only really needs to help you 1% to 2%. And if you're taking 20 different medications and each one helps you 2%, and you have an opportunity to be 40% better, just think of all the good things you can do with your life. I know that you want to be in life doing things, and that's what our job is. We want to help you do things, to work if you want to work, be a carpool mom if you want to be a carpool mom. Most of all, I don't want you to lose your family. I want to keep you in your family, and that's why we titled the show this way. So thank you very much. Stay tuned on CAW360 Nation, and thank you so much for CAW Nation. All of you are so loved by so many people, and we all want you to get better, so keep doing what you're doing. Thank you so much. God bless you. Take care. Goodbye for now.
Thanks for joining us for Keeping You in the Family. This program copyright 2019 by Dr. Margaret Aranda and CAW360. All rights reserved.
We are sorry, but the show has ended. Goodbye.